Yourself out of it. Good afternoon, everybody. We're going to get started with the program. First, I want to thank everybody for coming here, all our distinguished people from government, from academia, and all the normal people, too. This is an exciting event that I think we brought together a broad range of people to talk with us, from federal, state, and local government to academics to practicing attorneys, to really try to delve into these issues of what's important in disaster law or emergency preparedness law. And again, we have everyone from professors to providers to students to researchers here. So it's a good opportunity. We are going to start with a brief opening talk. Then we're going to have a moderated panel session. But most importantly, we want to have a dialogue with the audience. Now, we have a lot of people that are online, and unfortunately, we're not going to be able to dialogue with them. But we're encouraging everybody here to please think of questions, take notes, whatever you need to do, and we're going to take as much time possibly at the end for there to be this dialogue between us. I want to introduce myself briefly. I'm Tom Kirsch. I'm the director of the National Center for Disaster Medicine and Public Health. We're a kind of a unique organization in that we're half academic and half federal. We're housed at the Uniformed Services University, and we are the academic center of excellence for disaster science and public health for our nation. And this is, we just got done with a new strategic planning process, and this is kind of a kickoff to reflect on the collaborative nature of our center and the university that I work at. So with that, I'd like to thank the Georgetown Law, particularly the O'Neill Institute for National and Global Health Law, which is a co-sponsor here, and we're here at Georgetown. The Arizona State University Public Health and Law Policy Program at the Sandra Day O'Connor College of Law, and the Network for Public Health Law, which is a coalition that provides legal advice, resources, and connection opportunities for local, tribal, state, and federal officials, as well as legal practitioners and people in the real world. Brief background on the university that I work at, which is the Uniformed Services University of the Health Sciences, is the fourth co-sponsor of this event. It's a university that we call the America's Medical School. It's the only federally sponsored, funded health school in the country, made up of three different colleges: the Hebert School of Medicine, the Daniel Inouye Graduate School of Nursing, and the Postgraduate Dental School, as well as the Armed Forces Radiologic Research Institute makes up the school. And the school's purpose is to train healthcare leadership, physicians, doctors, dentists, that provide service to our nation and to our armed forces, and to promote the Leadership Academy of the Military Health Service. So we look forward to this opportunity. I'd like to introduce our keynote presenter, which is Larry Gostin. Larry, so I started trying to figure out what to say about Larry and discovered that he's a globally renowned expert in public health policy, law, and ethics, and frankly, there's just way too much to say. So I would refer you all to Google and Wikipedia. It's going to take you probably 30 minutes to read it, but it saves at least an hour here. I just want to give a couple of comments on his current university titles. He's the university professor, which is the highest appointed professorship in the university at Georgetown University. He's also a professor of medicine at Georgetown University, as well as a professor of public health at the Johns Hopkins Bloomberg School of Public Health. He's the founding O'Neill Chair and the director of the O'Neill Institute for National and Global Health Law at Georgetown Law. And he also directs the World Health Organization Collaborating Center for Public Health Law and Human Rights. So with that, Mr. Gostin.
Gosh, I didn't know I was giving a keynote. I thought I was just doing a welcome, but I can ad lib. Well, thank you very much for that lovely introduction, Tom. And let me first do the welcome. Really very pleased to welcome you here on behalf of the Georgetown University Law Center and the O'Neill Institute for National and Global Health Law. This summit on emergency legal preparedness comes at a really critical time in our nation and in our world. There are huge headwinds that we face, but perhaps the greatest headwind is our own administration, but also in Europe and other places where we've got a rise of ethnopopulism and a narrow country-first view, which is really the antithesis of what we like to think of as the major ideals of global health, because it's something that's against globalization, something that's opposed to the major goals of the World Health Organization: mutual responsibility, international cooperation, and the like. It's suspicious of international institutions. And so there are major headwinds ahead of us. At the same time, there are many opportunities. We have a wonderful new Secretary General at the United Nations, Antonio Guterres. Antonio was a real hero as the UN High Commissioner for Refugees. He brings deep experience and really cares about security and health. We have a new Director General that's about to be elected before the World Health Assembly in May. I just had lunch yesterday with perhaps the leading candidate, and he's extremely strong candidate. And of course, we have the UN Sustainable Development Goals, and particularly the health targets, including universal health coverage. So these are all really wonderful opportunities, but we also face these deep headwinds. Before I start my opening remarks, I just really wanted to thank Tom Kirsch from the Uniform Services University, James Hodge, my very, very dear friend who was a part of Georgetown for many years, a chair professor at ASU and the head of the Network for Public Health Law, and our own Oscar Cabrera, Anna Ayala, and Bridget Rader, who've done so much to make this possible. I've in the light of Ebola, there were at least four global commissions. One was an independent WHO commission, another was the National Academy of Sciences, a third was the United Nations Secretary General, and a fourth was Harvard Global Health Institute and the London School of Hygiene and Tropical Medicine. I served on two of those commissions and was a senior advisor on the other two. So I have a fairly good idea of the kinds of proposals that have been made. But the world is actually very deeply vulnerable to global health crises. We know that from beginning with SARS and its genetic cousin, another coronavirus, MERS. We know it from Ebola and from Zika. And now we have a yellow fever crisis emerging with a shortage of vaccines. And of course, really worrying H7 influenza in Asia. There are no less than 4 circulating avian viruses at the moment, with the potential to genetically shift at any time and cause a worldwide pandemic. I can't tell you, nor can anyone else. Tony Fauci often says this, and Tony really knows his stuff. We can't tell you what the next epidemic or pandemic will be, but we know with absolute certainty that there will be one. And it'll probably be among some of the circulating viruses, but that's not even certain itself. And yet, although we know this, the world vastly underestimates the risk. The risk is actually equal to, if not greater than, risks that we take much, much more seriously. Risks like nuclear or terrorism with the horrible Paris attacks. Bill Gates, for example, just made the point that there's no event on Earth that can cause as great economic, social, and human disruption as the next pandemic. And I think he's right about that. So we underprepare and we underinvest. And the question is why? Well, with this new America First view that I've referred to, and I've decided in my own mind to just disarm my scholarly neutrality for this administration. I have reasons for that. But I've decided to become extremely blunt, and I think that the facts on the ground justify it. But in talking with WHO, with leadership at CDC, where I was recently, and others, there's this new thinking that that the human case for preparedness and response is no longer enough. The social case is no longer enough. We need to also make a business case, an economic case. And so we're beginning to try to do that. One of the 4 global commissions from the National Academy of Sciences made an estimate of $60 billion per year from expected outbreaks. This translates to $6 trillion over the 21st century. Now, what makes this surprising, and I've just been yesterday at another National Academy of Sciences project that's trying to build on this work. What's surprising about it is it's as staggering a number as 6 trillion may be. It's widely thought to be highly conservative. So there's two things about this number that you need to know. The first is that it's not an estimated number. It's actually a predictable number. It's a number that we know will occur. We know it from historical records and modeling, both that confirm it. But the other thing that's striking about this is how conservative it is, because it only applies to direct costs of epidemics. It doesn't apply to the indirect costs of loss of trade, productivity, workforce, social destabilization, the effects on our health and hospital system, and all the rest. And if you look at other data, you can see a much bigger numbers. So, for example, the Economic Bureau predicted that it would be $500 billion annually, which is orders of magnitude more than the National Academies of Science. And the World Bank has predicted much higher rates. In fact, they estimate that a single event would cause a loss of 5% gross global GDP, which is an enormous hit on our global economy. CDC has been working on some modeling numbers, or actually not just modeling, but really what they're doing is they're looking at all first-order risk countries around the world, mostly low and middle-income countries, but not solely. I would say a lot of middle-income countries. And they estimated the trading value that we have with them, which is enormous, and estimating that with those partners, we have millions upon millions of U.S. jobs at stake. If they were to be hit by a crisis because they're unprepared, as they probably will be, the United States economy would suffer. So I'm never one that thinks about America first. I'll be very honest about that, because we're a global community. We're a world community. I care about Americans. I care deeply. I care about America. I care deeply. But I also care about the international community. And we need to kind of think about how we can build a response and a preparedness internationally that will be robust. The National Academy of Sciences, again, recommended a very small incremental investment of $1 billion additional per year that would keep us safe. I like to call this a security dividend or a peace dividend. It's really, if you think about what it would avoid, the cost is a no-brainer. And yet we don't do it. So what would we need to do to make the world relatively safe? Well, there are a number of things, but broadly speaking, there are three main areas. One is to have more robust health systems. The second is to have better global governance for health. And the third is to have a smarter investments, incentives, and platforms in research and development. And this is usually a much, much longer talk, but I'll very, very briefly, James, if I may, just run through these, and then we can build on them in the question time if it's helpful. So health systems are weak around the world. As you all know, the global governance framework for health security are the WHO's international health regulations. Those regulations have a mandate, a requirement, it's a treaty obligation, which the United States is a member of, that requires every state to maintain and to build and maintain core public health capacities. You all know what these are better than me, but they include the ability to detect, report, and respond rapidly to emerging outbreaks. And that requires infrastructure like a health workforce, laboratories, data systems, IT systems, and the like. And yet, when WHO was due on and required under the international health regulations to say that every state, every member state, a state party had achieved these results, it decided to kick the can down the road. And then when it kicked the can down the road, it asked countries who's not ready to report. About 87 said they weren't ready to report, and WHO just gave all 87 a pass. But even those that have reported, there's only a 27% compliance rate. 27%. And this is a way overestimate because they self-report, they self-assess. There is no independent evaluation of their health system capacities. There is no independent monitoring and accountability for complying with IHR treaty requirements. Now, WHO was castigated by all four commissions, including its own, for doing this. And so what it's tried to do now is to develop what's called a joint external evaluation. It used to be called the Joint External Evaluation Tool. Now it's just called the Joint External Evaluation. This is an evaluation that tries to have external peer experts come into the country, work with the peers in the country, and then have a fully transparent report going forward. There are only really one major problem. It's entirely voluntary. But wait, there's another major problem. There's no funding for it. And the only funding that we can see, the only possibilities, and I've talked to Jim Kim about this, is Jim is, of course, you know, the president of the World Bank, and Jim has had this idea of a pandemic emergency facility. That pandemic emergency facility, I've argued, should be tied to IHR health system compliance, and he's agreed to that. But I don't think the World Bank's facility is going to go there. There's nothing there yet. The bank isn't putting its own money into it. It's trying to get reinsurance companies. It's complicated, but so I won't go into it in great depth. The other, of course, is the United States-led global health security agenda. I think from most of the smart people I've talked to, it's very unlikely that the Trump administration and Congress will reauthorize that, which leaves the WHO's joint external evaluation in a great deal of difficulty. So in addition to health systems, we also need good global health governance. I've talked about, there are basically two global instruments. There are more, but the two big ones are the IHR, of course, which has a number of provisions, which has improved, I think, governance. And you can see this from, for example, China's handling of H7 compared to its handling of SARS. It's been transformative, really. But nonetheless, the IHR has not been complied with, and not only just in the health systems part, but whenever an outbreak arises and there's a public health emergency of international concern declared, governments, including the United States government, put on travel bans, travel restrictions, trade restrictions, and the like, which are entirely against the IHR and WHO recommendations. Of course, the other global instrument is the Pandemic Influenza Preparedness Framework, which is called the PIP framework. The PIP framework is really very good. It arose from H5N1 influenza when Indonesia refused to share its viral samples with WHO laboratories. After a 5-year process, the PIP framework has a benefit burden sharing scheme. It's really quite innovative. And it's innovative because it's not a treaty, but it may be more enforceable than a treaty because it has a contract provisions in it that can be enforced under contract law. So it's really very, very interesting. But it has major weaknesses. The two major weaknesses are, and they are almost insurmountable. One is the fact that it only applies to pandemic influenza. It doesn't apply to seasonal influenza. It doesn't apply to coronaviruses. It doesn't apply to any other pathogen. The UN Secretary General has recommended that WHO expand the scope, but WHO, Margaret and the World Health Assembly declined to do so, although they are trying to reform it. The second problem, and this is one that's really evolving and very worrying, not just from a health security point of view, but from a biosecurity and bioterrorism point of view, is that we're emerging in an era where we don't need a virus. We don't need to share a virus because we have genetic sequencing data. And we can now genetically sequence smallpox virus, for example. We can genetically sequence anthrax and a number of other areas, which raises major concerns, not only the obvious security concerns, but also the concerns about how the PIP framework or any governance framework can deal with that. Because although WHO claims otherwise, as a lawyer, I can tell you, and I advised them about this, that the PIP framework expressly took genomic sequencing data off the table because it was too hard to negotiate. It's not included, which is a major problem. The other problem is that there's a third international instrument which cuts entirely against the PIP framework, which is called the Nagoya Protocol of the Convention for Biological Diversity. This is a treaty which was really intended to protect the natural resources of a country. But countries are interpreting it as saying they own the virus. They own the virus and they won't share it, and this treaty allows them not to share it no matter what PIP framework says, even for pandemic influenza. And so we're in a stalemate at the moment, and we need a new Director General to be bold, have leadership, and push through it. Finally, and I know I'm going over time, is research and development. There's some really exciting things that are going on there. The WHO has a list of high-risk pathogens that it's using that have been widely, they've been complimented for. But more importantly, there's this new group called CEPI. And CEPI is a public-private partnership. It's got a lot of Gates money and other money. And what the idea is with CEPI is that it's going to try to identify the highest risk pathogens and make platform vaccine technologies. And they're going to all be on a shelf, but they're not going to be developed. And then when something hits, whether it's Zika, chikungunya, yellow fever, or whatever it is, yellow fever, we do have a vaccine already, they can take it off the platform and push it quickly into research and development. It's a very promising thing. But we need sustainable funding. The National Academy of Sciences report talked about the kinds of innovative financing that we need, because right now the private sector has all of the wrong incentives. Again, I don't have time to explain that, but I think you all know it. But the incentives are not to create countermeasures for emerging pathogens because it's too unpredictable. For them, the best drug is the one that a lot of people will buy, a lot of people in the first world will buy, who can afford it and afford patentable prices, and that won't cure you, so you have to take it for a long, long time. I guess the only exception to that is the $70,000 a pill hepatitis C, but that's affordable for most of us. Let me just end by saying that you, like me, I actually didn't stay up for the election because I was so sure Secretary Clinton would win. And I got up at 5:30 in the morning, put on NPR, and I was stunned. And I was so depressed. I just couldn't lift myself up. I wouldn't watch the news. I wouldn't do anything anymore. I was ashamed to be an American. I still am. And it's not just because of the policies. It's a matter of morals and decency. But I'm way past that now. I'm fighting. And for the young people in the audience in particular, I would say we need you in public health and public health law more than we've ever needed you before. So don't let this make you sad or lethargic. Let it energize you. When we were talking, I said, I wrote at the bottom, Trump. And somebody said, well, do you really need to be prompted? And I said, just when it fires me up. So let's fire ourselves up for a really great day today.
All right, everyone, we're going to convene the panel, and so in that brief 5-minute break, feel free to get up, go to the bathroom, grab some more water, get the lovely desserts if you haven't had a chance to hit those yet. I highly recommend the pecan pie. And then hopefully in about 5 minutes, we'll get started with the panel.
That's the grill.
Yeah. Oh, he is. Okay. Everyone to give them a little more space.
Oh, you want to move down?
Oh.
Oh, yeah, then you should be here, right.
Yeah, I'm just trying to give people more space. Not quite as. Do we have enough chairs? Yeah.
Okay.
I think so.
Thank you.
So you can sit.
Awesome. You are rocking. Thank you so much for doing that.
Okay. Get everyone up here. Oh, mine won't turn off?
I think those are on. So I think they're like voice activated, so they don't.
Yeah, they're on. Right. They won't project much, but they do a little. Oh, God. What? 500 billion? Yeah, 500, 600 billion, easy. Yeah.
Bring that question up.
Jim Blumenstock.
Tom Cruise, we haven't
Tom,
met.
it's a pleasure.
Nice to meet you.
My pleasure.
I was going to get
You're there for answers, not to pose questions.
Keep it going. Keep the pace going. What as you want with the pace. So in that respect, I would say we're not going to get to the last question.
Yeah.
Keep track of the time on the wall.
Yeah, I was going to run a stopwatch.
Good idea. And then just when it's 1:45, switch gears.
I forget who aired it, but it was all these clips of Trump, and whenever he sits down, he rearranges everything.
Oh, no.
No matter what, no matter if the water is here, he moves it here. If the thing is here, he moves it. And they showed about 30 different clips of this, and it was hilarious. Yeah.
You sure it wasn't Alec Baldwin that was doing
Yeah,
it?
right.
Well, this is not mine, so I'm moving it.
Right. Yeah, right.
Yeah, good timing. Okay, now we're missing a mayor and James.
Yeah.
Okay, go ahead, Lexi. I'm sorry.
still waiting for
There's
the
your
mayor.
mayor. Okay. Go for it.
All right, everyone, we're going to go ahead and get started with the panel portion. I am Lexi White. I'm a fellow at the Center for Public Health Law and Policy at Arizona State University. And I'd like to welcome you all here again. I know Tom gave us a little introduction, but thank you all so much for coming. We're really looking forward to having a great dialogue on issues related to emergency legal preparedness. And for those of you who are attending via online over there in the cameras, I said in the email that I sent out, but again, if you have any questions related to the panel or directed towards specific panelists, please address those to the Network for Public Health Law link that I sent out as well. So this panel is going to commence with a series of key questions for the panelists to consider, and then after about 45 minutes, we will open the floor for all of you attendees in person to ask specific questions directed at the panelists. Additional bios for everyone are available in the programs on your seats, but just to quickly re-go over everyone, we have Tom, who you already met and who introduced himself. We have James G. Hodge, who is a professor of public health law and ethics and the director for the Center for Public Health Law and Policy at Sandra Day O'Connor College of Law at ASU. We have Jim Blumenstock, who is the Chief Officer of Health Security at the Association of State and Territorial Health Officials, so ASHTO. We have Brooke Courtney, who is the Senior Regulatory Counsel for the Office of Counterterrorism and Emerging Threats in the Office of the Commissioner of the FDA. And then we have Umair Shah, who is the Executive Director of the Harris County Public Health Office, which is where Houston is situated. So with that, let's go ahead and get started. So our first question is related to public health emergency funding. So following the Zika outbreak in 2016, multiple bills were proposed to create a designated public health emergency fund. And President Trump has also recently included a federal emergency response fund as a line item in his budget blueprint. So Jim Blumenstock, what are the tangible benefits of this type of emergency fund, and what would these funds best be used for?
Great. Lexi, thanks so much. And again, good afternoon, everybody. I'm really pleased to be here with you. And a special shout out to my colleagues at ASTO. You're sitting in the back row because they could be holding up flashcards or cue cards for me as I go through my remarks. When I think of the conversation around the emergency fund, in many respects, it reminds me of the adage that the more things change, the more they remain the same. And when you think about it, there has been a fund since 1983. The conversation that policymakers had back 35 years ago or the exact same conversation we're having today. So let's reflect upon that. So what was going on when this law was created, when the fund was created? And that's the issue. You know, the fund exists, but the fund hasn't been funded. And nor are there the triggers and guardrails in modern day environments to basically manage that type of initiative. So back in the early 80s, what was Congress wrestling with? Well, you had swine flu in Fort Dix in 76, you had 3 Mile Island in 79, you had the HIV/AIDS epidemic in the decade, you had the Tylenol tampering, bunch of other foodborne outbreaks. So, again, Congress and the administration really realized that there was a need to provide additional resources for rapid and effective scaled-up response to these types of public health crises. The problem is that obviously in that conversation, there was another point of view. And this is sort of what it's rearing its ugly head today. And the other point of view is, well, there is a mechanism in place to address those additional needs. And the mechanism is that, the administration and the agencies and departments basically have to scan their resources, repurpose, reprogram, and address the needs and move from lower priority to higher priority, the necessary assets. And then if you need more money, you just come back to Congress and we'll go through an emergency supplemental appropriation request. And that's the issue we're dealing with today, is because precious time and energy is spent and lost following that paradigm. I mean, when you look at, the concerns over that model of emergency or crisis funding, and you go back and you sort of deconstruct the timelines. When you look at such things as Katrina, that was our hallmark. One day, Congress acted in one day and put money in place. Ebola, 42 days. H1N1, 51 days. Superstorm Sandy, 53 days. Zika, 235 days. Okay, so is that sort of a one-off, an outlier? And can we attribute it exclusively to the political standoff that was taking place at that time? Or are there other dynamics that really are surfacing here, such as fatigue of emergency crisis funding, maybe the belief that it wasn't as serious as the experts say it is, or the other issue is, is it a national crisis? It's regional, and there's gradients of what some regions being affected or not affected. So that is sort of what I guess the narrative and the paradigm that we're trying to shift through the Public Health Emergency Fund. So the good news is, I think, there really is groundswell support to making a difference in developing and funding this type of resource. We've talked about the legislation that's been introduced. Delorio introduced the Public Health Emergency Fund Act last year. Cassidy Schatz and others, introduced just several months ago the Public Health Emergency Response and Accountability Act. There's reference to funding this in the FY17 House Labor HHS committee report to create such a thing as the CDC Infectious Disease and Response Reserve Fund, and even President Trump's blueprint or roadmap, the skinny budget, there's specific reference to a federal emergency response fund. So clearly you have not only the practice community rallying around it and publishing such documents, and our colleagues at the American Association of Public Health Laboratories actually dedicated their last edition of their journal, the creation of, Racing to Respond, the case for a public health emergency fund. APHL, ASTO, all the others, including TIFA, have really rallied around that, but including from a bipartisan perspective. So, assuming we get into sort of a stronger and better place for the creation of a fund, where there's a will is a way, but the devil is always in the details. And it's the details, getting now to your question, of really what do we have to be sensitive to that will, at the end of the day, will give us the resources and the flexibility and the speed to use the money, but also provide the appropriate level of accountability and transparency and comfort in Congress who's going to put this money in place. And we also have to manage the message to make sure we don't get swept up in a zero-sum game type of discussion, that if they're going to move monies out of annual appropriations for program work to support the funding of this fund, that we don't want to lose on the other side by having our programs deteriorate as well. So I mean, that is a key issue. And the other message is this is just stopgap funding. You know, when you look at the type of emergencies that we have experienced, you know, H1N1, you know, if we have another pandemic and we need to launch a national vaccine campaign, you know, the 300 million, the 500 million, that's sort of the numbers that have been talked about. That even for the vaccine campaign, that is not sufficient to do what the nation would have to do in that scenario. So the messaging is we need stronger foundational day-to-day support. We need the emergency fund that can give us immediately turnkey abilities, but also realizing that Congress, we're still going to have to come back to you under the circumstances and ask for more resources. So, you know, and we also have to make sure that we don't, you know, get into sort of creeping as to what we mean by emergency. So the conversation, for the most part, is around those high consequence pathogens, infectious diseases. And the discussion is, well, should something like a Flint, Michigan, okay, an environmental catastrophe, be eligible for tapping the emergency fund? Or something like the opioid epidemic that may be more, you know, longer term, chronic, you know, but still a public health emergency. Is that fair game for this type? And that, you know, sort of the broader you think about what an emergency is, the more pros and con dynamics come in and could also freeze us up in progress as well. You know, the triggers, you know, clearly some type of secretarial declaration that seems to be sort of the gold standard for a lot of the other emergency provisions that are in place. And I think, you know, let me stop there because I know the others on the panel may want to react to that, but I think that's, you know, to summarize, I think we're in a better place now than we ever have been as far as the conversation and bipartisan support. It's an issue of, you know, what can we do as a community of practice to seize that opportunity, put in place, so there are also no unintended consequences about having this new resources available. Thank you.
Yeah. Any other comments? We have a lot of questions to get to, so I'm sure we'll circle back on a lot of these central ideas that Jim mentioned. This next one is for you, James. So the CDC published its final rule on the control of communicable diseases this past January 19th, and it was designed to help modernize previously antiquated policies regarding public health responses to new and re-emerging communicable diseases. So what does this new rule prescribe, and how will it affect the balance of power between federal, state, and local entities responding to public health emergencies?
Yeah, Lexi, that's intriguing. Just the way that's framed. How's it going to affect the balance of power in public health on some of the key, almost, you know, quintessential public health powers of isolation, quarantine, other issues related to this? This is a seminal change you're seeing in relation to what CDC pushed through without doubt right before the beginning of the Trump administration, following months of review for its specific draft proposals. On January 19th, just days before the inauguration, this final rule from CDC goes into place. Now listen, CDC has always had the power under various different federal acts to do issues related to quarantine, isolation, social distancing, surveillance. It's had these powers for years, but they were antiquated as affected in regards to regulations. This effort by CDC to upgrade those regulations really does go a lot further than what we've seen before. It improves those regulations in so many different ways, and so we applaud CDC for clarifying a lot of what and how its agency working with state, local, and tribal officials can respond. Let me give you a couple highlights. This is exactly the sort of stuff I expect you may have questions on afterwards, and my panel members as well may have some outstanding comments to raise as well. Here are the highlights. First of all, these new regulations, though dense and at times a little difficult to follow and read, do a great job of actually laying out what federal agents at CDC, consistent with HHS, can do in relation to emergency preparedness legally in regards to surveillance activities, in regards to monitoring activities, and in regards to apprehension, quarantine, and isolation authority. Things that were not well spelled out before have been now. That's a very significant improvement. And so a couple areas of expansion that we saw in relation to this are quite important to realize. First of all, surveillance and monitoring. CDC's all over that, not just at airports, as you know, with their quarantine stations and such. At every major transit hub in the United States, CDC's now authorized bus stations, train stations, any transit hub, any interstate movement of individuals, or as per this now rule with effect, even purely intra-state movement of individuals within transit-related purposes. CDC can now approach in relation to some of the implementation of these powers. So that surveillance monitoring has always been there. It'll be strengthened by this rule. Let's focus on the social distancing powers. That's what got interesting fast. And it's where CDC took a lot of comments, 15,000 plus, in relation to crafting this final rule. We're talking now about the ability of an agency with 9,000 employees to actually systematically apprehend, isolate, and quarantine Americans with or without state and local input in relation to who should be isolated and or quarantined under what circumstances. Mostly reserved for public health emergency circumstances like Jim was talking about, but the emergency creep factor of this is also at play that Jim was mentioning nicely. CDC doesn't have to declare some state of emergency, nor does HHS through the public health emergency issuance to use these powers. It's enough that they have reasonable belief that somebody within the United States or coming in through our international borders may present a specific illness or condition for which would otherwise result in quarantine or isolation measures. That's a substantial sort of new breadth of power that CDC can use unilaterally, whether state or local governments like it or not. CDC can now do this. So you say, okay, that's a little bit concerning. They can apprehend for 72 hours. They can isolate or quarantine. There are very good due process protections in place, neatly written out in the rule, process protections that are essential to making sure this can survive constitutional scrutiny, unquestionably. But there's a couple problems too. Like Larry was quick to point out, there's good news, but the problems may surface. Here's one of them. That reasonable belief standard I just mentioned. CDC can apprehend, can isolate or quarantine for a brief period of time, 72 hours or so, based on the reasonable belief that somebody presents with an illness that may be sufficient for purposes of it landing on that list of quarantinable conditions. Supreme Court's never approved that standard. They're looking for a higher standard of clear and convincing sort of evidence or something stronger than the reasonable belief of a federal agent that somebody may fit within that list. That will be problematic. And then there's the due process issue related to the purely internal assessment of these concerns through CDC agents only. They have not sought any outside input in relation to when and where it can use these powers. So if you're subject to apprehension or isolation pursuant to this quarantine rule as put into place, it will be CDC agents alone making those determinations. Again, generally through due process, we're looking for some level of outside confirmation for something as serious as a physical restraint of your personal liberty. These could be tripping points. Beyond that, some of what you're seeing in the new CDC rule is a really great improvement over what was in place. But the potential for it to act outside of local or federal, or I'm sorry, state or tribal authorities, even knowing of CDC intervening, that could be trouble down the road too.
Yeah, thank you, James. And I think this theme of this balance between federal, state, and local is something that's really going to play out over hopefully all of these panelists' responses, since we have such a wide variety of levels of government represented. So switching gears a little bit, earlier this year, FDA issued final guidance for industry and other stakeholders on EUA's emergency use authorizations of medical products and related authorities. And these guidelines cover not just pre-EUA activities, but collaboration in advance of a CBRN emergency and also emergency uses of medical countermeasure products. So Brooke, this one's for you. What are the known and projected applications of this new guidance related to the issuance of EUAs in response to future emergency events?
Great. Thanks so much for the opportunity to be here and to represent FDA and to everyone for showing up on a Friday afternoon. The brief answer is that this guidance mostly clarifies what we've been doing for a number of years with respect to our medical countermeasure authorities. But as background, including in FDA's responsibilities of regulating, I think the most recent estimate is over $2 trillion worth of consumer goods, is advancing the development and availability of medical countermeasures, so the drugs, devices, biologic products like vaccines, to protect the nation and also the warfighter against chemical, biological, radiological, and nuclear threats, and that includes emerging infectious disease threats like Ebola, Zika, pandemic influenza. The goal is always to have approved medical countermeasures stockpiled and ready to use in advance of an emergency or at the time of an emergency. But we all know that that's just simply not always possible because we're dealing with new threats and all sorts of different deviations of emergency responses. And so when it comes to countermeasures, sort of we're dealing with kind of two issues: availability issues and operational issues. Availability, where sometimes the best product for a response, if a countermeasure is needed for a response, might be an unapproved product, or it could be an approved product that might need to be used in unapproved ways, such as a product that might be approved for adult populations but not for pediatric populations. We have operational issues as well, where there are a number of different sources of countermeasures. You could have countermeasures coming from the Strategic National Stockpile. You could have countermeasures stockpiled at the state, local, or regional level, or they could be commercially available. And ultimately, responses occur at the local level. But federal law comes into play because FDA regulates medical products, the use of medical products. We don't regulate the practice of medicine, but we do regulate the medical product use. And it can become particularly important during an emergency when you're dealing, especially with novel threats, to make sure that we know as much as we can about the countermeasure and effectively balance the risks and benefits to make sure that we're not using products in a response that might cause more harm. So we have a number of legal tools that we can use that are outlined in this guidance that we recently issued. The one that I think people are most familiar with is our Emergency Use Authorization Authority, where again we can authorize the use of unapproved countermeasures or the use of unapproved uses of approved countermeasures based on a number of different statutory criteria. The authority to do that was established by the Project BioShield Act in 2004, and then it was amended by the Pandemic and All Hazards Preparedness Reauthorization Act, or POPRA, which I think we'll be talking about in a little bit, in 2013. And POPRA also gave us a number of other countermeasure emergency use authorities, which I'll talk about briefly. The EUA authority is interesting in that it, while FDA is responsible for issuing an emergency use authorization, we can't do that unless the HHS secretary declares a specific kind of EUA declaration, which is separate from a public health emergency declaration. It's a specific EUA declaration, and that declaration has to be based on one of 4 different emergency determinations. So it gets a little bit complicated. One of those determinations could be either by the DHS secretary, the DOD secretary, or the HHS secretary. There are a number of layers of sort of checks before we're able to issue an EUA, and there's a lot of coordination involved with not only within FDA but with CDC, usually with ASPR, with BARDA, and others who are involved in this. So we also, just a brief note about the EUA authority is that we received some additional amendments to the authority with the 21st Century Cures Act, which was enacted in at the end of 2016. So we now have the authority to be able to issue EUAs for animal drugs. So we're still working on the interpretation of that authority. And at this point, we've issued about 36 EUAs. An important thing is that we can have these in place for preparedness or response purposes. The goal is sort of that, if we know about a threat like H7 and 9, Zika, Ebola, where there might not currently be an ongoing emergency, but we know that enough about the threat that we want to be ready, we can have these in place for to respond. We have EUAs in place for a number of in vitro diagnostic devices to help with disease detection. So I think we have something like 12 for Ebola, 15 for Zika, and just last week we issued an emergency use authorization for a chemical nerve agent countermeasure, which was the first one we've issued in that space. And then POPRA also gave us a number of other emergency use authorities for approved medical countermeasures, things like being able to extend the expiry dates of countermeasures that are stockpiled. It's one of the big concerns, sort of, okay, so we have approved countermeasures available, they're stockpiled, they're ready to go, but they have a shelf life or a labeled shelf life. And there's a thing called the Federal Shelf Life Extension Program, which is limited to federal stockpiles like the Strategic National Stockpile, DoD medical material, and so on, that is a partnership with the Department of Defense and with FDA, and we work to do scientific testing to see if a product can be used beyond its labeled expiry date. And it's pretty rigorous, periodic, ongoing testing. There's been a lot of interest at the state and local level, and I'm partially responsible for this because when I worked at the local level, I was pushing for this, so I'm partially to blame. Now I have to figure out how to solve it. But we now have this authority to be able to sort of outside of the SLEP program, be able to extend expiry dates of other countermeasures. So we've been working on, hopefully to be issued soon, a guidance document that would allow state and local public health partners do their own testing of stockpiled doxycycline for anthrax preparedness and be able to extend those stockpiles. So we're really looking at innovative ways to use these authorities. Our guidance that we issued earlier this year outlines those authorities and how we use them, but there's a lot more that goes on, and again, we work closely with state and local partners. We work with ASTO and HO and others, and CDC and ASPR and a range of partners on these authorities.
Great, thank you so much, Brooke. So next we're going to move on to the mosquito in the room, Zika. So as I'm sure many people in the room are familiar, Zika has impacted individuals in over 60 countries globally. We have thousands of cases here in the United States. Some recent CDC data that was released, I think just last week, suggested that 1 in 10 pregnant women with Zika in the US give birth to infants with known birth defects. So not surprisingly, a variety of novel public health strategies to combat Zika spread have emerged, including the use of genetically engineered mosquitoes. So Umair, we're going to turn this to you first, our local expert. What are the legal or policy issues related to the use of cutting-edge emergency public health techniques?
Thank you.
It's working.
Yeah. Oh, okay. Thank you, Lexi. Maybe my ears are burning because I thought you were referring to me as the mosquito in the room. It's great to be here. Let me just start by saying thank you to James and the group here to invite me up from Texas. When he said this, it sounded like a great idea, except when I showed up here, I realized that it was hotter here than in Houston, which is really a rarity. I guess where I would go with responding to this question is that it really, I think what Jim did in terms of describing the number of days that it took for the Zika funding to get approved through Congress, the 235, the number, I'm dyslexic, so 253, right? The number of days that it actually, when you think about that, at the local level, we couldn't just wait. And it's not that we can just say, well, geez, it's taken us such a long period of time. And as you know, the President Obama's initial proposal was for $1.9 billion, that eventually what was passed was $1.1 billion. And as those dollars were passed, and obviously this happened in the previous administration, we did not see dollars getting into the local community. In fact, some of those dollars still haven't gotten into the local community, and some have not even gotten to the state fully to really be open about it. And so if you think of that context, at the same time, a community such as ours that's right in the radar of Zika, mosquito-borne diseases, subtropical climate, humidity, all those kinds of things, is that we really very much have to turn over every stone and really think about what we need to do to protect our community. And that oftentimes means that we have to be outside of the box. And so traditional mosquito abatement efforts or mitigation efforts of spraying, really in the case of Zika, we found, except for that the move in Florida where you saw that there was aerial spraying that was done, but previously it was really that we can't spray our way out of this situation, is that we really need to be relying on our communities to do source reduction and to remove all the different, I know she's laughing. That was my quote, and Brooke always laughs when I say that, so I have to be very careful that I'm not sitting next to her at a panel. So, you know, it has been very, very challenging because we have to really be thinking about what are those technologies that we need to potentially incorporate when just doing that routine engagement, awareness with our communities may or may not be as successful. Just to give a little bit of an idea of volume, Harris County has had about 80 plus cases of Zika, all travel associated, which are more than a quarter of the cases in the state of Texas. Texas ranks number 4 after New York, Florida, California in terms of the number of cases in the country. And in Cameron County, which is right on the border, we actually now have cases of locally acquired Zika. Our department has investigated 1,112 reports of Zika with 929 rule-outs and 183 referrals. And the reason I bring up those two statistics is that that's busy, right? Just because you're referring and just because you're ruling out or just because you're not fulfilling at the end of the day, a case that gets positive, you actually still have a lot of work, that tremendous amount of work that goes in. So what are we doing from the technology and the emerging technology standpoint is really to say that we can't rest on those laurels. And so we are the first health department to work with Microsoft Research for these smart traps that are essentially these traps that, of course, it's Microsoft, so you can imagine that this is a lot more technical and complicated than I'm about to describe here. But infrared technology, and you have some ability for the infrared technology, actually robust ability to check the oscillations of the wing flapping of the mosquito to decide if it's the Culex mosquito or the Aedes mosquito, and then to trap the specific mosquito, grab it, and do all these data analytics on the back end. Yeah, it's really pretty cool. And that is a technology that certainly in and of itself is not really that controversial, right? So we have traps that are traditional traps. We've either replaced one of them with this technology, or we've augmented by having two traps together, one being a traditional trap and one being the smart trap. But there's a phase 2 to that, which is the use of drone technology. Okay, and that is really, in our vision, is everything from having the drone go up in the air and scan what's happening in neighborhoods, see where you might have standing water, and eventually proof of concept is to take that technology and be able to actually have the drone drop the trap and then even potentially pick up the trap and come back. And that's the vision. But now if you can think about that, there are a lot of legal issues when you think about government with the drone going over your neighborhood, identifying, right? Those are the challenges that we have. And fortunately, that's phase 2, and we're still in phase 1. And we're going to talk to Brooke so that we can figure out, and James can figure out how to actually solve that problem.
The mosquito definitely has some informed consent issues.
Absolutely. We're also encouraging the mosquito to use safe sex practices. But the other that you've probably been hearing about is the Oxytec with the genetically modified mosquito. And this actually got our attention about a year ago. And we've been talking and working with Oxytec on what this potentially could mean in Harris County. But most recently, our local newspaper got a hold of the fact that we were doing this. And the next thing you know, they titled it Mutant Mosquitoes as being the title. And of course, that got a lot of attention. And we were doing a ton of interviews to really describe what we were doing. And where this becomes an issue, and this is a technology where, again, you have a male mosquito that when that male mosquito is with the female mosquito and they have progeny, that the progeny do not grow up to be adults. And so you sort of have this, the equivalent of a die-off, if you will, and over time, that genetically introduced mosquito is supposed to take over for the wild mosquitoes that are out there. And that's the technology that we've been looking at, but it's not just we, it's also been Florida, and I'm sure Brooke can talk a little bit about that, is that there was a long period of time where we were waiting to see if the Florida request to the FDA was through the comment period was going to get approved, and that eventually did get approved, and the trials, the okay to move forward in that went were pretty much deemed by FDA it's okay to move forward, and then the community said no, not in our backyard, and so then the Keys had to really look at a different community, and now going back up to the FDA for the location piece, and then the question about is it FDA or EPA, because now there's some movement of potentially this being approved at the EPA agency level. But what it does still is at a local level, such as us, at our level, we still need to be thinking about these technologies, and the Keys, just another technology that you may have heard about is Wolbachia, the sort of bacteria, again, that you lace the mosquito with, and this bacteria actually makes it so that the eggs don't hatch. And so there are some things that really are very much about technology solutions. We think all those solutions are absolutely in play because we cannot cover the size of a Harris County, which is 1,778 square miles, which is larger than the state of Rhode Island, for just our traditional techniques. And so we have to think outside of the box, but as you can imagine, that opens up a whole host of legal and other policy considerations. So let me stop there, because there may be some additional comments that
Yeah, I was going to say, Brooke, if you want to really briefly add something, we still want to get through a couple more questions, but if you have like 1 minute response.
Okay, I'll try to do that. So, I mean, I think Umair has really summed this up well. It's just that there is no silver bullet when it comes to Zika, and we're dealing with particularly wrenching issues when we're talking about women and children and families and changing the course of people's lives. And to see some of the human impact of this, I'm not sure if any of you have seen the new CNN film, Unseen Enemy, but there's some interesting footage in that film about some of the women and babies who have been impacted by Zika. So, and as someone who was pregnant most of last year, it was just especially, I had much more of a sense of a mission working on this issue last year and continuing to. The current sort of efforts at FDA, just to reiterate, there are no FDA-approved countermeasures, no drugs, devices, vaccines, or anything at this point that have been approved at FDA to treat, prevent, or diagnose Zika. But again, this is sort of where our legal and regulatory authorities come into play. We have authorized under EUAs about 15 different diagnostic devices, which are really critical, and not just with clinical diagnosis, but also with disease surveillance, and being able to figure out, where disease is occurring and where interventions might need to occur. FDA is responsible for regulatory oversight of the blood supply, so we've done a lot to sort of make available some investigational tests to help screen donor blood, and we've issued guidance recommending that all blood collection facilities in the U.S. Screen blood. We're working on vaccine development, but obviously there are a lot of challenges associated with that when we're dealing with women of childbearing age and preventing infection in fetuses. I think when vector control and contraception really are some of the more sensitive issues and raise some really interesting legal issues. With the genetically engineered mosquito case, with Oxitec, for example, and we are allowed to talk about this because the company gave us the permission. Usually I can't talk about specific products that are under development, but in this case we can. But it raised some really interesting issues where FDA was involved in regulating the product because it's considered an investigational new animal drug, although, again, we're looking at these authority issues of where EPA versus FDA should be regulating these types of products. So there's some guidance out now. If anyone is interested in commenting on that, the guidance has been extended to June 19th. But the Oxitec issue really raised this issue where the Florida Keys Mosquito Control District was involved. The company proposed doing a local field trial. Some people in the community were opposed to that. We've been working with the company and going through different authorities like the NEPA, the National Environmental Protection Policy Act, and so on, where eventually we ultimately issued a finding of no significant impact to allow the field trial to continue, but that's not where it stopped. It wasn't an approval, it just allowed this one particular field trial to continue. But as Umair mentioned, the local mosquito control district and sort of other authorities come into play in many cases, although mosquito control varies across the country at the local and state levels. But in this case, there was a vote against it. But I did hear that this week that the Florida Keys launched a Wolbachia trial. So we'll see how that goes. And again, EPA regulates that. And then just a brief comment about contraception, just that access to contraception varies and access to sort of reproductive choices varies in countries that are impacted by Zika. So it's raises some really interesting legal issues that are not necessarily in FDA's domain, but I think in public health law really raise some critical questions there.
Yeah, thank you, Umair. Thank you, Brooke. So again, shifting gears slightly, we're giving you a really wide range of issues with these questions. This one is for Tom. So in 2016, CMS published its final rule on emergency preparedness requirements for Medicare and Medicaid participating providers and suppliers. And it requires them to establish emergency preparedness plans, including policies, procedures, communications plans, testing, training, all by this November 2017. So if you could talk a little bit about the significance of this rule and what you see going forward with this, that'd be great.
Thank you, Lexi. Yeah, so as a physician and a disaster responder manager, to me this is a critically important rule. This is something that has been an ongoing issue with healthcare provision for decades now in our country. We have, I guess for background, everyone has to understand that the provision of healthcare after disaster or public health emergency is not something that's voluntary. It's a critical, we just define it as critical infrastructure, no different than power, sewers, water. It has to exist. And so the need for intervention, regulation, et cetera, in my mind at least, again, as a physician, is enhanced because of that reason. For decades now, we've had rules for hospitals, both legal rules from CMS, other federal agencies, as well as internal rules from the Joint Commission and other regulatory bodies that has engaged hospitals and forced them to become prepared. And this has not been true with other healthcare facilities for the most part. And despite the lessons that we've learned in Katrina, and again, the lessons that we learned in Sandy, we kind of bypass this. So the CMS rule specifically addresses 17 types of other health provision facilities like psychiatric outpatient centers, surgical centers, and particularly important to me after seeing events in Katrina and Sandy is long-term care facilities and nursing homes per se, because those are a big issue going forward. This type of rule has been discussed again from decades, particularly since Katrina, and it wasn't until Sandy that the political will became strong enough to pass it. But it's really a rule that's been a long, long time coming. It addresses three kind of major recurrent problems that we've seen in these events and other events, both globally as well as nationally, which for the most part is the concept of what we call surge capacity. Surge capacity is the ability of a healthcare system to absorb the extra cases that occur in a disaster, particularly something like an earthquake, but also hurricanes where there may be injured and ill. But we disrupt our own surge capacity because when a health facility closes, or as we've learned, a long-term care facility closes and they literally dump their patients onto the local hospitals, we disrupt our own ability to provide care for those who are injured in the disaster event. And so this regulation, this rule, is to help to address the surge capacity. It also, underneath that, is when all these transfers occur, we have now for decades been losing patients. After Hurricane Sandy, there were 6,500 patients approximately evacuated from the New York hospitals in the region, and some of the patients couldn't be found by their families for weeks afterwards because we had no record on where they went. The same occurred in Katrina, the same occurred in Liberia when I was working there. Again, it's a very common problem. The final issue, the issue of power, is specific to this rule. The rule actually addresses two different things. It requires these healthcare facilities to create an emergency preparedness plan. They have to have a plan, they have to do an analysis of risk, they have to train people, and they have to test the plan. It's simple, standard planning that Walmart does, and local governments do, and everybody else does, and it requires these ancillary healthcare facilities to do the same thing. It also has very specific rules about power. And the anecdote I like to give about power is when a hospital or healthcare facility loses power, it loses its ability to provide care. After Hurricane Katrina, I testified in front of a Senate committee, and the person in front of me was a CEO from one of the local hospitals in New Orleans. And he gave a long talk about how important it was to prepare and how difficult it was to get supplies and this and that. And at the end, one of the senators said, "Sir, if there's one thing you could tell the American public that's important for everyone in the future, what would it be?" And he thought for a second. He said, "Never put the generator in the basement." And yet, in Hurricane Sandy, one of the major New York City hospitals, they had moved their generator up to the 3rd floor, which is great. They left the fuel pumps in the basement. So the generator quit working, and the employees at the hospital spent hours carrying buckets of gasoline up to the 3rd floor in order to feed the generator to keep the people alive on ventilators in that facility until they could be evacuated. So again, from these personal anecdotes, to me, this is an incredibly important rule. There's been a lot of discussion about the implementation of this rule. It took years to develop. There was a lot of feedback. The Congressional Budget Office held it up for a considerable period of time, considering the cost of the individual facilities, particularly with the generator rule, because it's not cheap to put in generators for facilities. But it's an important issue. The question on state versus federal here, the argument that you can make in regard to promulgating a federal law for preparedness is that the risks with these healthcare facilities are markedly different. If you're a hospital on the beach in Florida or on the beach in Long Island, we now know, then you have a great deal of risk that you face. If you're a hospital in rural Arizona, where I'm from, there's essentially no disaster risk there. And so why should the federal rule be uniform across all of these different things? It's a difficult question to answer. In my mind, that is answered by the fact that despite all that, states and other local governments have not necessarily stepped in to address these problems. And simultaneously, CMS pays for Medicare and Medicaid patients. There is an inherent importance to them for continuity of care and provision to their beneficiaries. So, therefore, I think that's the reason that CMS finally chose to promulgate these regulations. And again, from my very biased perspective as a physician, I think they're incredibly important.
Thank you, Tom. So we'd hoped to get to a couple of more questions, but I think at this point it might be best to turn it over to all of you guys and see if you have any particular questions. We have a microphone in the center of the room, but I think this room is small enough that you could probably just stand up at your seat and project loudly and we'll be okay. Yep. No, it's fine.
For the audience online, it'd be better.
Is this on? No.
I think it might be.
I think it's on.
Yeah, it's on.
It's on.
Okay. Hi, I'm Leila Barraza from the Zuckerman College of Public Health at the University of Arizona. And first, I want to say thank you to our great panelists. It was a very informative panel. And while my question is directed at Dr. Shah, I would welcome insights from any of you great panelists today. But I'm currently working on a project related to preparedness at airports. And Dr. Shah, being from obviously one of the most populous counties, which includes one of the nation's busiest airports, are you aware of any local ordinances or policies that allocate the roles and responsibilities for county health officials versus airport officials in response to an emergency?
So, Layla, thank you for your question. Let me explain a little bit about how the county-city dynamic works in our community and how it works in relation to the airport, because I think that helps describe my answer, or at least gives context to I don't know. But explain to you what I'm getting at. So Texas is a home rule state, so we have every city is able to make ordinances within their own jurisdictional bounds. However, counties have to actually rely on the Texas legislature, which meets every 2 years for about 5 frenetic months, which is going on currently, and then it stops, and then you have to wait another 2 years for you to restart the process. Outside of that, we are unable to actually change law from that standpoint. It has to be at that legislative process. However, the city of Houston, in this case, has the ability to put ordinances in place. The two airports actually fall under the jurisdiction of the city of Houston, not the county. Yet, county and city both respond if there is an emergency at an airport, but now it gets even more complicated because we also have the CDC quarantine station at Bush Intercontinental Airport, and that's another area because now you have jurisdictional bounds that are very much related to the federal government, in addition to all the other, obviously, agencies that are at the international airport that are in place. So it becomes very complicated quickly because we've actually had situations, especially around Ebola, where a passenger arrived, there was some handoff or coordination with federal, state. State was involved a bit too because they were getting some information through the federal system as well, and locals, and we were all, involved in, is this somebody with the symptoms that might be consistent with Ebola because of their flight over from Africa, et cetera, et cetera. But then that individual actually lands at a city of Houston airport, it's at least in the jurisdiction, drives out, and now goes and lives in a county part of the jurisdiction, which is not the city, and it's unincorporated Harris County, or to even be more complicated, passes through Harris County and goes into Fort Bend County, which is actually the county next to us, not even part of the city county. The dynamics are incredibly complex, and this is why collaboration and communication and incredibly important handoffs, as Tom mentioned, as from the ER standpoint, as that ED perspective, when you're leaving your patient at the end of a shift, it's so critical that you have good checkoff and handoff to the next physician coming in. Because if you don't do that in the public health world, we will have gaps and we will miss things. So long caveated answer is that it depends, because it really depends on what's going on in that scenario and where that individual lives.
Yeah. Thank you.
If I could add too, that was an excellent summary, and I think to reinforce, it's the handoff issue. And I think that, the passage of the promulgation of the new CDC quarantine communicable disease rules will allow all of us in the practice community to take a fresh look at it, possibly go through some, tabletop exercises, some functional exercises, because it's not only the public health community. You have Customs and Border Protection that have responsibility literally on one side of a line. You have law enforcement that parallel the public health communities in these different jurisdictions, and it's just not infectious diseases. We obviously we saw it with Ebola. We also saw it during Fukushima, worrying that people were repatriating or escaping from Japan, and whether they had radioactive, where they were radioactively contaminated, and what we do as a public health community for screening, monitoring, and handing them off, not only through the various jurisdictions that Umar talked about, but also if they needed clinical assistance. And of course, you have decon and everything. So it goes way beyond infectious disease, but I think the new CDC rules will give us all better tools and a new opportunity to look at this.
Yeah, and just being very brief on that front, the CDC rule does envision this scenario, and it's spelled and framed to address it. So you don't need an interstate situation any longer. A intrastate is sufficient. CDC officials can step into that situation when it arrives at the airport and then escalates from there. But when a major outbreak occurs, you're not going to have the federal agents on hand to do any of that. They're going to have to work with state and local government, and it's going to require that coordination the mayor talks about, starting from the airport and on down. So, yeah, tremendous responsibilities on that front.
If I could just add one more thing, was that the Super Bowl was obviously an incredible game, depending on which side you were on. Super Bowl 51 was played at NRG Stadium, which was a county facility within the city jurisdiction, surrounded by all sorts of federal and other kinds of monitors and response folks, including with the BioWatch program. And you had this incredible amount of folks that were descending in. And it was a non-event, right, from a security standpoint, public health standpoint, but still incredible amount of collaboration and resources that needed to go into that response piece. But again, here now you had a county facility, but surrounded by the city. And so there has to be this joint back and forth collaboration. Otherwise, it just doesn't work well.
Thank you.
Thank you, Leela. So I think we'll take one question, and then I'm going to be incredibly greedy and throw in another one about POPRA. So I think I saw one right. Oh, I think.
Hi, I'm Netta Squires with Montgomery County Office of Emergency Management and Homeland Security. And one of the things that we're kind of struggling with these new CMS guidelines is, well, we're trying to go to all our surgical centers and everyone and say you need to get this done. And I think part of the guideline was perhaps they had to submit it. And so putting on my EM hat, said, right, of course I want to see this. I want to make sure that they're good and everything. But if we're not required to actually do that, we're not. Then my legal hat says I don't want to have them because that kind of says to the center, yes, you've complied with everything that needs to be. So do you have any sort of recommendations or guidance on how to handle that and how?
So do you know the actual law?
No.
So I'm not an attorney, I'm a doctor,
Perfect.
but I've read the rule a lot.
Just weighing it down.
I put myself to sleep at night reading the CMS rule. So I'm not giving you legal advice. My understanding is that there's a need to collaborate and they're using the Hospital Coalition and the HPP program kind of as a model to direct this. And so there's very specific language that I'm aware of that says that the facilities have to work with local government and officials to collaborate across these things. I can't, not being an attorney, say that that's a law. The language encourages heavily to have these collaborations and the oversight by the local governments, but I don't know the exact wording of it.
And just to help you with that, Netta, I mean, that is a really good and precise question. My best guess right now, and I'm not trying to just conjecture on this, but my best guess is if you want continued CMS funding, you're going to engage in these specific issues, and they can always put the funding side on it as a sort of penalty should you not conduct this. But I tell you what, that's exactly the sort of question the network answers. So with that, we'll look back a little more carefully at the regulation and get your response back to that. If you drop us your business card or send us a quick email.
That'd be great. Thank you.
Good.
So I'm going to throw in another question, but we'll send it back to you guys, so don't worry, you're not cut off. So talking about POPRA a little bit, so it was reauthorized in 2013, and it developed new authorities to sustain and strengthen national preparedness for public health emergencies. So what are the lessons that we learned from POPRA, and what should be steps going forward in maximizing its utility? So Jim, we're going to send this to you first.
This is a great conversation. So, and it's a great time. POPRA's going through reauthorization, so the next year and a half, we all have an opportunity to influence the third generation of POPRA. It was passed in 2006. That was informed in large part from its predecessor, the Bioterrorism Preparedness Act of 2002, and of course 9/11 and anthrax. It was reauthorized 2012, 2013, and that was informed in large part through our experiences through the H1N1 pandemic. So when I look back to see what 4 items I believe the public health community had great influence on, that was a success story, was provisions for the temporary reassignment of state and local federally funded personnel, a huge issue during H1N1 where state and local jurisdictions had hundreds of workers paid for out of categorical federal grants and couldn't be mobilized for the H1N1 response because they were paid for by another categorical program, WIC, maternal and child health, you name it. So this law actually allows the secretary through a declaration to allow those employees under certain terms and conditions to be redeployed and be temporarily assigned to respond to the crisis. That was a success story. The Shelf Life Extension Program that Brooks summarized, a huge issue for states and locals that had hundreds of millions of dollars worth of medical countermeasures, mostly Tamiflu at the time, that we were worried that was going to time out. The ability to give states 2-year spending authorities on 1-year appropriations provided a little bit of relief on that. And of course, the emergency use authorizations that Brooke talked about as well. So now we look at, here we are in this day and age, I think all the conversation in large part will be, talked about our experiences on Ebola, Zika, and possibly Hurricane Sandy and Flint. So what are some of the areas that I would predict that are going to come up? Number one, I hope not, but, the discussion around the emergency fund. I would hope by time POPRA gets reauthorized, that's moot, but you never know. But that clearly would be an opportunity to address it then. The FEMC, the Public Health Emergency Medical Countermeasures Enterprise. The law typically, the law basically has a lot of impact or input upstream. in the research and development. And we're, from our perspective, the practice community, it's the state and local public health officials and the healthcare community that are basically the mechanisms to put the drugs into the communities and into the people. So to have a little bit more influence and say in the FEMC process and whether or not that needs a statutory fix or not, that's something that we will be talking about. The other issue around vector control. PAPA and PAPRA require a number of strategies to be developed, including national health security strategy. We don't have a national strategy on vector control like we do for hepatitis, HIV, developing one for the opioids and drug abuse. Why not vector control? We had, H1N, West Nile virus, a decade and a half ago. Recent years, chikungunya and dengue. We talked about, yellow fever. So the issue is whether or not PAPA would be reauthorization would be a good opportunity to sanction the creation of a national strategy for vector control. The World Health Organization yesterday announced that they're developing a global plan to eradicate or control the Aedes aegypti mosquito. So, that's just one indication. And then, the issue of funding level authorizations. PAPA authorizes funding for a lot of the programs that build the infrastructure. So we want to make sure, obviously, those numbers that wind up in the authorization are critically important. Other areas that may be talked about is the role of ASPR, the Assistant Secretary for Preparedness and Response. The law established that position and over the years improved and enhanced the role and responsibility of that executive. Who knows? When we were dealing with Ebola and the White House determined the need to create the Ebola czar because the public health, the U.S. government system was either overwhelmed or dysfunctional to a point that there was no designated leader. Will that be just treated as a one-off political thing, or is that suggesting that maybe we have to look at PAPA and other legal frameworks to determine whether or not there's a better way to have cross-agency coordination in the future. PAPA provides a lot of resources to the communities. Typically, the funding uses population principally as a sort of a surrogate for need and risk, and whether or not there'll be increasing conversations of defining what may be a risk or a need in the community that will influence what jurisdictions get or don't get through the various cooperative agreements. And a couple of other areas real quick. Through the Hospital Preparedness Program, which was PAPA created, the strategy is to develop healthcare coalitions, which is basically an administrative creation. So the question is, are we at a point now with that strategy and that maturity that there needs to be some statutory recognition and designation of coalitions? So that'll be a conversation within the practice community. I think there's also a need for clarity between preparedness and response. I personally think a lot of times there's an artificiality saying one thing is preparedness and the other thing is response, but in some of the letter and intent of the law, there may be some gray areas as to what states and municipalities could use funding for response versus preparedness activities. So I think clarification and really improvement in that area. And the one last item I want to throw out, and some of you may not even be familiar with this, but the public health community mobilizes a lot in a non-Stafford Act way and due to non-Stafford Act types of incidents. So that sort of creates a different situation with command and control and the federal, state, and local interface. Recognizing that, HHS has moved forward and created this entity called the Unified Coordination Group, the UCG, and to sort of mirror image or parallel federal presence in an environment of response to ensure that there is a good federal-state integration and coordination. And whether, again, the Unified Coordination Group, it was piloted in Flint and also in Puerto Rico for the Zika response, whether or not, again, that's at the level of maturity and success that it may need and benefit from congressional or statutory designation or representation. So those are a couple of areas that I think we're going to be looking at to see what the national conversation is, what our members in the practice community think are important to make a great law even better.
And Brooke, Tom, do either of you have anything to add?
I just wanted to add a bit about the HBP, I guess, in the comment about how does preparedness flow into response. The healthcare in general in the U.S. is a kind of low margin business, and the incentive to spend millions or tens of millions of dollars on a single facility to prepare it for an event is relatively rare, particularly in areas that are not accustomed to common disasters. And so the HPP and other programs like the CMS rule have specifically designated funds to assist the healthcare system in preparedness. The HPP program specifically builds these coalitions, and this goes back to this regional concept like Katrina and Sandy again, where a bunch of hospitals close, they dump their patients. You can't just do one facility preparedness in the healthcare system. You have to do regional preparedness. There's just no way around that. And so the HPP specifically is designed to encourage hospitals, states, local governments, et cetera, to create these coalitions, to create these regional response surge capacity events. And to me, that's one of the critical important functions of the POP reauthorization that really needs a careful look at and consideration in regard to preparing our nation to respond to the critical infrastructure needs of our healthcare system.
Brooke, just a quick comment that, POPRA was really an exciting opportunity for us, and we really took what we learned from previous responses and working very closely with state and local stakeholders over the years and our federal partners over the years to figure out where we needed to improve and what new authorities could help us do that. So, as mentioned, that we were given a number of new authorities that we helped to develop related to the use of approved medical countermeasures, for example, because we had heard from a lot of state and local responders that that the EOA authority was just cumbersome for approved countermeasures. And so, we worked with to develop some flexibilities with that. And then again, with the expiry dating extensions for stockpiles and so on. We don't just have these authorities on the books, we're actually actively using them on an almost daily basis. We're using them and working, and hearing about needs at the state and local and federal level and how we can best use and apply those authorities. And so looking forward to, I'm not sure what we're calling it, if we're calling it POPRA, what are we calling it? POPRA 2. Just kidding, but yeah, exactly. So we are looking at some just in the early stages, looking at some technical amendments and how we can either further refine the use of some of those authorities. But Jim provided just a great overview of the broader issues. So I don't have anything to add.
And I think just the point is, this is a great time for everyone who's part of the community really to provide input. I know next week at the annual Preparedness Summit, there are multiple sessions, panel meetings, just to basically scan the environment to get people's ideas and thoughts. So really we could come in and meet with the committees and have really a solid list. And if everyone sort of stands behind sort of a tight list of reasonable requests, like happened twice already on this, I think it'll just move us so much further forward.
Thanks. So any more questions from our audience? Do you both want to come up and you can do them in order, or?
Again, thank you so much for being here today. What a pleasure it is to be here with you and Georgetown Law for hosting this lovely event. My name is Fred Stein. I'm with the American Association of Colleges of Osteopathic Medicine, fourth-year medical student. And I was just wondering, we talked so much about Katrina and some of the implications therein, and I remember, the New York Times did a particularly scathing article just about some of the actions taken by physicians and providers during moments of, of incredible emergency and some difficult decisions that had to be made, some triaging decisions that were made that ended up in the, quote unquote, euthanizing of humans. And I was wondering, since that event, how has the legal notion of whether it's coverage or creating accountability and transparency of physician action or provider action in a emergency preparedness or disaster situation evolved? Thank you.
I was going to say, James, Omer, do you want to duke this one out? Or?
Great. This might be one of those great questions to just run down the panel with like 15 seconds each from each, because this is a good point. It's actually one of the topical areas on the liability side and such that we thought through for potential introduction here today. So let me be brief and suggest we have totally transformed the information or the political environment around those types of cases. They're high profile, and while they're rare, the potential for doctors and clinicians to be liable in these events and hospitals, aka in Dallas and other places, to be liable is the biggest factor that might create its own crisis alone. Healthcare workers and hospitals unwilling to provide care because of those crisis events and liability facets are really highly problematic. PrEP Acts come into play to introduce really strong liability protections at the federal level for medical countermeasures. But what you really look at in relation to this, while there is no saving grace to a single federal act or such that would immunize all persons in this particular scenario, what and how we digest this is almost through an umbrella type of approach. If you take any declared event in the United States and start noting who could be in the liability path for making tough medical triage decisions, I can open an umbrella at that point legally and start to show you here's how they're protected from liability. But to the student's great observation, medical triage is one thing, legal triage is another. And if you don't engage in that simultaneously, you don't have practitioners ready to respond. Mayor?
Yeah, I would just, to add to what James just said, and I'd be remiss if we didn't point out that Larry Gostin and Dr. Dan Hanfling, Dan, if you can raise your hand. He doesn't know why he's raising it. He doesn't want to go very high.
Well, I think he knows.
Yeah, he knows.
There's a mosquito in the room.
There's a mosquito in the room, yeah.
Another?
Yeah, Larry being the chair and Dan being the vice chair for our Institute of Medicine at that time, National Academies, obviously now, Crisis Standards of Care Committee that James was on, Brooke was on, I was on, and I'm sure there may even be a couple other folks in the room. And what I would say is that we have made a tremendous amount of progress since then, and that was 7 years ago. There was a lot of real interest at that time. In fact, it came out of the Katrina experience and the fact that you actually did have practitioners who were doing the best that they could under a very chaotic and fantastically horrific scenario that were then at the end of the day vilified because of potential actions that they took in the midst of that emergency. And that brought through these crisis standards of care, and there were 3 reports that came out eventually. And really, I'd make sure you refer to those, because when Tom was referring to surge capacity, that really is very much about what do we do in the midst of catastrophic surge, and how do we make these kinds of decisions that are very critical to what's happening in our communities. And I want to make sure to point that out, James, as well. In the interest of time, I won't go any further, but just to say that has now been incorporated with the HVP and the FEP guidance to really be part of surge planning and really what states and locales and communities and healthcare institutions need to be doing in terms of their response planning.
And, sort of added to that, James had mentioned the PrEP Act. There is also concern about the use of unapproved products and concern about liability with a whole range of medical counter development, from manufacturers, developers, all the way through program planners and healthcare providers who actually administer the products. And so there's the Public Readiness and Emergency Preparedness Act, or the PrEP Act, which was enacted in 2005. It's an HHS authority, but it allows for, when a PrEP Act declaration is issued, it can provide liability immunity for a range of actors involved in the development and use of medical countermeasures, whether they be unapproved but allowed for use under an emergency use authorization or under an investigational new drug application, or one of our other medical countermeasure authorities that we have under POPRA. So there's a lot of interplay again with the authorities at HHS and FDA. There is also the potential for a compensation fund to be funded. HRSA oversees that. It can provide funding for people who receive a countermeasure who then receive an injury that's directly the result of that. So there are some really important protections involved in that. And I think, the issue of, where product liability comes into play was just even highlighted last week, where there was an over $450 million fraud verdict against a surgical gown manufacturer on claims of misleading buyers about its protections against diseases like Ebola. So these issues are real, and as we know, they occurred during, a number of events that high-profile events we're aware of, but they continue. And so these protections are really important for encouraging development of products, and then also for encouraging their use during an emergency, and then protecting people, who receive them.
All right, I think, oh,
In addition to reading CMS rules for fun, I occasionally read ethics. And so I'd like to turn it to an ethical argument. And so in regard to the Katrina situation in particular, physicians are taught specifically we have to care for the patient in front of us, whoever that is. Ethically, we are taught that there's different ways of doing that. There's active provision of care. There's passively not doing anything that allows someone to die. There's withdrawal of care where you make a decision to take them off the ventilator. And then there's killing them. The physicians, my personal belief in this situation, killed these patients. They actively killed someone. And to me, the ethical standard that goes to that leap of interaction, of intervening, is horrible and should never happen. When we worked in Haiti after the earthquake, we were overwhelmed with thousands and thousands of patients. We created what we called the eternal care unit, where we were going to put people to die because we didn't have enough care. We couldn't provide care. No one in the hospital would do that. So not only did we not actively kill people, there was no one in this overwhelmed hospital that was even willing to put people to passively die into this thing. So to me, what occurred in Katrina is beyond the pale, and I won't go beyond that. The important distinction here, though, is there's medical ethics where we have to deal with the individual patient. You're my patient. I take care of you. I do my best. I optimize your care. And then there's public health ethics where you're looking at the greater good of society. We have tried to rectify the gap in those two things with the crisis standards of care. I do not believe that's true. When there is a large disaster where the entire medical system is overwhelmed with thousands of patients, we pretend that we're going to do our best as physicians to provide care to the individual patients, but we are going to have to make decisions to let people die, period. There's no way around that. And so the current discussion in crisis standard cares and other stuff, although touches on that and raises a lot of very important issues, we have not as a society, partly because of the risk of malpractice, partly because of death panels and the Obamacare discussion, all of that stuff, we have not had the courage, I believe, to truly address that we are going to have to make decisions to let people die. And as a physician, that's an appalling thing for me. I can't do that.
I just wanted to point out, I'm just going to say in the crisis standards of care, there was really a real notion around palliative care. Compassionate for that very issue that, Tom, you're referring to. And I think Dan has
these are all great comments, and the questioner obviously struck a nerve within the audience. So I'm going to go back to James's umbrella, because I think the umbrella is key. And that umbrella, in my mind, is the notion of creating a plan. And so there's no question, Tom, this is a conversation that needs to continue to percolate across provider community as well as communities at large. And there are states now that are taking that on. The challenge is 5 years hence from the completion of almost 5 years hence from the completion of the last report, I think we've seen 12 states out of 62 awardees that have really fulfilled a completed plan. So it just speaks to the complexity and the challenge and the idea that, and again, like Tom, I'm a doctor. I watch the lawyers on TV, although it's a real honor to be with these great lawyers, on our committee. You're going to be better prepared if you can point to having thought about this pre-event and have some degree of plan. Even though there's no case law, we don't know how it's going to be upheld, amongst the jury, but you're going to be potentially more easily defended, having said that you worked on this and thought about it, than just going in ad hoc. And unfortunately, at the end of the day, decisions that were taken by those doctors and nurses at the Memorial Hospital are easy for us to retrospectively, question. I think their biggest liability was that there had been no forethought in a community that knew it was at risk for a catastrophe like what ended up.
Yeah, Dan, we've got one additional question we want to get to, which we'll get to right in a moment. But the truth is, the hospital in New Orleans suffered and settled for $25 million, not so much on what it did, but for what it planned or what it failed to do in relation to its planning. So that, along crisis standard of care planning, can be quite instrumental. So, Lexi, I think we have time for one more question, yes?
I think we saw one over there. Yes.
Yeah.
Excellent.
My name is Sarita Vanderbilt. I'm the Director of the Office of Legislation for ASPR. I think we
All comes back to the money.
As everyone knows, we are going for a reauthorization right now. ASPR has been very diligent in terms of putting together some proposals and working with our counterparts across the department. The Public Health Emergency Fund is currently in statute. So a question that I often get is, why do you need another fund? The problem is we're not receiving an appropriation for this current fund. How will you better able to get money if you have a second fund that will also need appropriation? So just because you have an authorization, again, doesn't mean you have the money. So can the panel please speak to that in terms of why we need a second fund?
So, yeah, so I don't know if we need one. You know, the point is that what often is called is the triggers and guardrails. You know, what would it take for Congress today to have the level of confidence and assurance that if they put money in this account, it will not be a slush fund? Okay, and the question is the current statute, the 1983 statute with its revisions, sufficient enough to garner sufficient congressional support to put money in place? And if the answer is no, we need more statutorily mandated provisions to make sure that it's not misused, or you don't have drift or shift. You know, then it's either revising the 1983 law, putting it in PAPA, or supporting one of these other freestanding initiatives, if that's what it will take to move the legislative machine to get us to where we want to be. So it's not my area of expertise. We have a bunch of options, but the end game is getting the fund funded.
Excellent, Jim. Thank you. Thank you all for those great questions. I'd like to take the opportunity, first of all, to thank my great colleague at ASU, Lexi White, for a very nicely moderated panel, and all of our panelists. Thank you. You heard Larry Gostin talk about at the beginning of this session what we have to do in relation to global health initiatives and planning from a global communal perspective. And to be sure, those are daunting challenges. Thank heavens we have somebody like Larry and so many others on the global mission that are actually working towards that objective. I see the same sort of daunting challenges from a law and policy perspective for us in the United States in relation to these preparedness issues. We convened the summit on the premise that under a new administration, we might see some of these challenges come to the forefront, and it's not even been remotely tested yet. As we all know, that test is around the corner. Being prepared for it is what we should be doing. You've heard from these panelists so expertly today about the types of challenges we still already see, learned historically, and now to the forefront in the very near future with whatever that next various pandemic or other type of test may be. I think today offered us at least an opportunity to launch that next objective on the U.S. scale. Can we now use and mobilize law and policy as the effective tools for better response in this administration as we go forward? The questions are out there still. I just want to remind everybody, do let us know, all of our panelists, the Network for Public Health Law know, our colleagues at Georgetown. Let us know these questions continuously and let us attempt to answer them as a community. I think if we're successful in that regard, we will pave a pathway forward that will actually lend well to the next inevitable emergency response. It's Friday afternoon. I want to make sure everybody gets out of here on time. Thanks to Georgetown, thanks to our colleagues at the Uniformed Services University, for all of my colleagues at ASU, including colleagues here in Leila Barraza, Lexi White, and for all of us at the Network for Public Health Law, thank you for joining us. Have a great afternoon.
Oh, thank you. Thanks for the opportunity. Thank you.
Someone asked the liability question for us.
Yes. Well, it's
That's a good idea. Somebody's got the
Safe travel. I'll see you tomorrow. Next week.
Yes.
Next week.
Yeah.
Forward to it.
Yes.
That's so expensive. I mean, there's only a couple people in the whole country that can talk about this like
I know.
It's such a great, and you guys went through so many excellent points.
So we were trying to take
I know
I cut my beard.
good exchange. Really powerful.
Thank you for the opportunity. But I'm wondering, I'm thinking such a short conversation and so many issues.
Yeah. The summit with NATO next week.
Are you going?
No, I can't be there for that.
I won't be there.
I know
My first year.
Greg will. Greg will cover.
Greg.
So, but, to be sure.
How are you? I might write something up for input. Oh, you're interested? Oh, it looks like a one-page report. Oh, that's
How are you? Nice to see you.
Yeah, we're interested.
How are you?
You just, you have all these questions and you have so much you want to say.
Lively, it had the flow to it. I think we were looking for good with it.
Yeah, I did. I like had him over there. Like, do we go for the proper questions? We know.
And I like that you showed nobody. But that was a good success.
Yeah, because we hit the 45-minute mark and I sort of I felt like my goal was like when I saw it was basically everyone was running about 7 minutes question. So I was like, I think we can get to.
I knew we'd never get to the last.
It was like I think we can get to Popra, but then we hit 45 minutes and I was like, oh, let's. Yeah.
Because we knew we wanted to get to it. And
Yeah.
somebody else, the liability
Yeah, I was
side.
going to
So
say
that
liability we hit.
basically, we hit all the major milestones. And I think that came across really nice, very smooth, very polished. The panel did what you needed them to do. The accumulated audience provided a great setting for just about what we envisioned.
Yeah.
So really nice. So glad we could pull that off.
We needed a whole nother hour for that panel.
Oh yeah, yeah. They'll be doing half-day stuff on this at the emergency summit in Dallas. Actually, Atlanta next week.
Yeah.
So, to be
Why
sure.
is everyone in Atlanta this year?
No, it does seem like the whole world's going there for every conference. But this went really well. So thank you. That was really nicely, expertly modeled. So there's really good ones. All right, I'm going to run. Then I'm going to to the restroom, and then I'm going to be packing some stuff up. Leland,
See you next week. Yep. Every 6 months.
No, I forgot to. Real